Yes, okay. Good afternoon to you all. To this MDPI webinar on how to avoid a new lockdown. This is the first webinar of a series we plan in the coming weeks. We have participants from all over the world, but first of all, I hope that everyone is healthy and fine in these turbulent times. My name is Matthias Burkhalter with MDPI. I'm organizing the coming World Sustainability Forum to be held from 15 to 17 September 2020 at the CCG in Geneva, most probably in a hybrid format, but this will come out later and we will inform you about that in due time. For questions, please only use the Q&A function to be discussed after the talks. We have prepared a poll which will open in a pop-up window at the end of the webinar. After the webinar, you can directly interact with the panelists if you wish so by raising the hand, and you will eventually be granted to go online. And now it is a great pleasure for me, and I would like to pass the word and introduce you to Antoine Flahault. He is a medical doctor and director of the Institute of Global Health at the University of Geneva and chair of the Geneva Health Forum to be held this year from 16th to 18th November 2020 in Geneva. Antoine, please go ahead and open the webinar officially.
Thank you very much, Matthias. And it's a good pleasure for me to participate in this webinar and to discuss with you how to avoid a new lockdown with this COVID-19 nightmare and tragedy we are living together. So if you can display the PowerPoint, dear Matthias, I will maybe go to the next slide. The next slide is a summary of the natural history of COVID-19 as we know it. In fact, it's already outdated and some figures may not be true. But I think it was a useful slide to show you because the case mix of this disease is quite amazing. Most of these disease forms are mild forms or moderate forms, or sometimes with no symptoms. Probably in 30% of infections with COVID-19, there is absolutely no symptoms, and we think that this state may be contagious. It's probably one reason of the expansion of this virus was the fact that it has some mild, moderate, and even asymptomatic forms, which allowed this virus to travel without being detected by temperature screening or by any means, and it spread out of the world very quickly due to that, which is a major difference from another coronavirus disease, which was named SARS, and which was completely eradicated after its outbreak in 2003. The two other forms are more severe and lead to hospitalizations usually, and they represent 15% of cases, 5% out of the whole population of infected people may complicate to NARDS, an acute respiratory disease syndrome, which leads to intensive care and sometimes to a bad prognostic and death. The next slide, please. Next slide is just something to show you that the diagnostic test through PCR, which is a biotechnological test, is very specific because it is the sequence of the virus which is identified when it is positive, but it is not so sensitive, meaning that there are a lot of false negatives. You can be negative because you don't capture the virus in your nose, in your pharyngeal mucosis, and therefore you may be negative but carrying the virus, for instance, in your lung. there is another mean which has been developed by Chinese, which is the scan, CT scan, which may detect very early some pulmonary lesions, which are very specific of these COVID-19 infections. So probably combinations of both may be useful to increase the sensitivity. The next slide. I will have finished with the medical side to show you now some epidemiological feature of this disease. There was a very interesting paper published in the New England Journal of Medicine a few weeks ago, saying that the impact of an epidemic depends on three characteristics: the numbers, transmissibility, and clinical severity. Next slide, we will consider the numbers first. The numbers, and particularly the official numbers, as taken as today, show this reported number of cases, reported number of deaths, and recovered people. And they are very well available today on a daily basis, sometimes updated several times a day, which is completely new. It is the first pandemic. Even in 2009, the pandemic flu was not accurate as it is today for this coronavirus. I show you three types of numbers, the cases, also the numbers from the test, the PCR test I mentioned, which are not performed at the same level in various countries. South Korea is a leading country in number of tests performed. You can also adjust that with regard with the number of citizens, and Switzerland is quite high. Of course, the more you use tests, the better you have a picture, but we will see that it is not only a question of epidemiology, it is also a question of disease management or outbreak management. I will come back to that very, very important point later on. I also presented on the right side of the slide, the Diamond Princess experience, if I can say that, it's awful as a word, which conducted a cruising ship to be quarantined with 3,711 passengers and crew members. And the attack rate was 19.2%, 712 confirmed cases. Among these cases, a lot of them were asymptomatic, more than the 30% I presented in my previous slide, because some of them were not asymptomatic for all the time. They were just pre-symptomatic. Before the symptoms, you have no symptoms, you are asymptomatic, but 30% of them were asymptomatic. And we had to deplore 13 deaths among these cases, which is a rate of 1.8%, which is probably one of the most accurate rate because it is a closed environment. These people were, however, older than a general population of Switzerland, for instance, but it gives some accurate figure here. The next slide, please. Show that quickly there were a lot of uncertainties on numbers. When the official coronavirus count in China was 12,000, that was the 1st of February, the Hong Kong University, through a model, estimated that 75,000 cases were, in fact, occurring in Wuhan at that time. The discrepancy was probably not because they were hiding figures, maybe yes, but it was because there were a lot of asymptomatics which were not detected in the healthcare systems because they never consulted for that. Another debate was about the count of deaths in Wuhan when it was seen that many more urns were collected by people to mourn their dead than expected. And maybe 4,000 people died due to the coronavirus or related to the coronavirus during this period of time. Next slide, please. Whatever the uncertainty, I think that we can assume that these bias, maybe hidden figures or more likely underreported figures, are more or less constant over time. They are occurring everywhere. And they are constant over time, with some exceptions. When you change your definition of case, it may change very, very quickly and very dramatically. And when, for instance, France decided a few weeks ago to take into account those who die from the coronavirus in home care facilities, it has made a dramatic change in one day. But without these exceptions, we can try to predict the disease for ahead of time. But we refrain in our team to predict more than 8 days ahead of time, and we provide this epidemic forecasting on a daily basis, every evening, using the data which are reported to the official authorities. So we rely on these official accounts because we do believe that if there are any bias, any underreporting bias, and I present here the figures for Switzerland, but even for Switzerland, we are completely aware that the figures are not exact, but the trend probably are. Next slide, please. I have now to talk about transmissibility, and the next slide is about this R0. The basic reproductive number is an essential parameter of the mathematical theory of infectious disease. R0 is a variable. It's not constant. It has a distribution. I have not found the distribution of the R0 for this new coronavirus so far, but I plotted on the right panel of the slide the R0 distribution of SARS in Singapore in 2005. And you can see that the distribution is close to the R0 for this coronavirus, 2.4, but it has some outliers, some what we name a super spreader event, which are prone to trigger 20 or 25 secondary case per index case. Because what is the basic reproductive rate? It is the number of secondary cases which are distributed by one case. No, it was a good slide. I apologize. No, next one, please, Matthias. Yes, this one. The R0 is a theoretical figure. You cannot estimate it. You cannot estimate it directly. You have to estimate from an equation which is given in the slide. I apologize for that, but you need to have the doubling time. You know, the doubling time is a time during when the number of cases are doubling. And when you have this time, it may be 3 days, maybe 4 days, maybe 6 days. Here, I took an example where it was 3 days. You have an R0 of 2.4 with an infectious disease period of 6 days. The next slide shows why I am talking about this reproductive rate. You need to keep this reproductive rate below 1 if you want to control the pandemic. So the R0 is, by the mathematical theory of infectious disease, a product of 3 parameters: the probability of transmission, the contact number, and the generation interval. The generation interval is more or less the duration of the infectious period. It is 5 days. But the contact number is a number of people you meet during your day, your life, and who are able to transmit the disease or to acquire the disease if you are infected. So it's not any contacts in the street. It is the people you are close enough and long enough to transmit the disease, and the probability of transmission is a probability. So I just put some figures. If you have a generation interval of 5 days, if you meet 5% per day, you need a 10% probability of transmission per person to have this 2.5 or 2.4 R0. The next slide, please. I want to show you that if you want to keep this reproductive rate below 1, you need to reduce the 3 parameters I mentioned. So first, how can we reduce the probability of transmission? By the protective masks, hand washing, also these safe coughing practices we mentioned. And of course, if we have available some antivirals or some vaccines, it will play a leading role. Next slide, please. If you want to reduce now the contacts, you have to implement what we name the social distancing measures. And the social distancing measures can be distinguished in two categories. One is what I will name the personalized social distancing measures, which is what have been implemented in Singapore, in Taiwan, in Hong Kong, in South Korea, in Japan. And it means that you test, you practice mass testing, you test a lot. You test before the cinema, in front of the cinemas, you test in front of the university because everything remains open. With that, you don't disturb a lot the daily life of the people, but you test them a lot, even on the roads, drive-through testing and so on. You also identify through this testing some people living with the virus. You have to trace their contacts extensively using many people to help you, but also using artificial intelligence and all the tools available for better contact tracing. When you trace the contacts, you may identify new carriers of viruses, and therefore you will isolate them. If they are healthy, you can isolate them in hotel. If they require some healthcare, they may go to the hospital, of course. But with that, you don't mix them together in household with healthy people. The second method, second option, is the population social distancing, which can be named as lockdown. It has been initiated by the Chinese and it has been followed by most of the countries in the world. It includes school closure, restriction of gathering, depending, can be 5, can be 10, can be 50 or more, restriction of movement of the populations, and cordons sanitaires. Sometimes when there are some outbreaks, you can completely close some areas. Next slide, please. The generation interval, it's not a variable which is easy to reduce. We can try to shorten the infectious period. That would be very, very good for reducing the R0, but we don't have antivirals today to do that. Of course, we may use some more symptomatic drugs like antitussive, but it's not very effective to date. Next slide, please. The third point is about the clinical severity. As I told you earlier, majority of cases are mild. However, 5% require some intensive care, and about 15% may require hospitalization. It may depend also on the countries, but it is more or less these figures. In Italy, in Lombardia, and in France, and in European countries, the percentage of cases went to the hospitals was more 10% than 5%, but it depends also on the strategy of testing. Because if you test only the more severe cases, maybe not severe only, but of course you can imagine that you may have a lot of, you may concentrate the critical and the severe cases. The case fatality rate is very difficult to assess in any emerging infectious disease. As I told you, we can just rely maybe on the provisional estimate, which is provided by the Diamond Princess, which is about 1.8%. I am not saying that the case fatality rate is probably 1.8% because the population of the cruise ship was older than the general population. I am more or less in line with those who say that the case fatality rate, if you take the number of deaths and you divide it by the number of infection, whatever the symptomatology, so accounting also the asymptomatic people infected by the coronavirus, it is probably around 1%. Next slide, please. That allows us now to rank this pandemic of COVID-19 among the various pandemics which occurred in the last century. And what is clear now to most of the experts is that we are very close to the Spanish flu pandemic, which was what is sometimes said the mother of pandemics, because it was the deadliest pandemic the humanity has ever had. And it is much more severe and transmissible than the pandemic flu of 1957 or 1968, and of course of 2009. So both the severity and the transmissibility put this disease very close to the 1918 pandemic. What we have to say is we are not in 1918 for many, many reasons, not only chronological. We are not just after World War. We are not at a status of development as we were in 1918, and the population of the world and the connectivity of the world is, of course, not the same as it was in 1918. Next slide, please. You have probably seen many times this figure, which was, I think, very important to understand what we did by all these lockdown and measures we took to not suppress the pandemic, but to flatten the curve and to delay the peak of the pandemic. And that was what happened. The next slide, please, is to see what we mean by flattening an epidemic. You can see particularly well in the Switzerland, the figure for Switzerland, which was shown by journal Le Monde last week. And we showed that we had reached a plateau in Switzerland, which is quite visible here. And you can imagine what could have been the curve if we had not done anything. So most probably, the reason why it has been like a plateau, it is just because we have flattened successfully the curve today. Of course, you may contest this reason because causality is always difficult, not only in epidemiology. So to attribute the success of this flattening to the lockdown measures is something which may subject to debate, because of course we can imagine that it is due to, for instance, the season and not only the intervention measures. In France, you have also a plateau which is very high, but very similar. Next one. Because we have flattened the curve, and because most probably we will not succeed to reach the herd immunity, and the herd immunity, which is also derived from the mathematical theory of infectious disease, is something which has been calculated to be around 70%. When we will have reached 70% of the world population being immune against this virus, we will maybe turn the page and say game is over. But until that, and of course, this immunity is not necessarily acquired by having the disease. It may be, of course, also added by vaccine. But without a vaccine, we will continue to have waves. And in fact, it's not something new. I just plotted on this slide a couple of examples in London, in Copenhagen, the United States, in the UK, where you can see several waves of the same pandemic. That was pandemic flu in each cases, but that was in various period of time. What I want to tell you is that most of these pandemic flu occurred during winter. Winter time is represented here by the pink bands. And of course, sometimes it was up to June for 1889 in London. Sometimes it was starting in September, and sometimes you have some small outbreak in July, but the big outbreaks were mostly in winter. The reason why I think it is possible to imagine that there will be also a seasonal force which will maybe slow the process of the pandemic currently or in the upcoming months, but with a strong risk of second waves and third waves after. The next slide, please. So, how to lift this lockdown? Next slide, please. Prior to lifting the lockdown, I think we need to ask 5 questions. The first is, what was the objective for this lockdown? In fact, the objective to know if we want to lift, we need to know what was the objective for. If you wanted to suppress the pandemic by this lockdown, you cannot lift now the lockdown because it is not suppressed yet. It's not eradicated. Eradication is not only a dream. For SARS has been completely eradicated. So it may happen that in the community, some people wanted to eradicate it, but we need to be in agreement on the objective. If not, that will be difficult to assess, to fix the criteria. So if the criteria is to flatten the pandemic curve, you can say, okay, we understand when we have flattened the pandemic curve, we may consider now that the lockdown was a success. Why did you want to flatten the pandemic curve? That was just to avoid a surge in the hospitalization, in the healthcare system, and mainly in the intensive care units. So, when do you want to lift the lockdown? In fact, you cannot lift the lockdown during the plateau because you understand that all these measures are temporary measures, short-term measures. If you lift these measures, you will obviously increase the contact numbers. You remember now the formula. So these measures were done to reduce the contact number. If you lift it, you will increase the contact number, and therefore you will increase the R, effective R. In fact, the effective R needs to be below 1, and to be below 1 means reducing the curve and receding. The epidemic is receding. So you cannot start your lifting when you are in the plateau, but you can start it when the epidemic is receding, when the level is as it is in Austria, for instance. In Denmark, I'm a bit more concerned because the epidemic was more in its exponential phase when they decided to start lifting. I put here 2 countries which decided to start the lifting early. The third question is there a seasonal force against COVID-19? I cannot answer to that question today because it's too early in the season, but we may have 3 options. First is we have a strong seasonal force. It happens very well with influenza. You never experience any influenza in temperate zone in the Northern Hemisphere after May. And you may have in June or in July or in August, some cases coming back from New Zealand or from Australia or from Chile with influenza. And sometimes there are some chains of transmissions, but usually it never leads to any outbreak. I am talking about temperate zone, not about intertropical zones. I'll come back on intertropical zones if you have any question on that, but it is a completely different story. The influenza is circulating all along the year in tropical areas. It may happen that the seasonal force is not strong, but it's not completely absent. It may be something in between, a limited seasonal force, which may help the lifting of lockdown. The fourth question is the level of immunity. If the level of the immunity of the population has reached the herd immunity, the 70%, it will be okay. If it is a low level, it will be a much more risky situation. And of course, you may have heterogeneous situations where you have in some part of the country this high level of immunity and some other parts some lower level. But when the level is high, you have a safe situation. When the level is low, you have a much more risky situation. When the seasonal force is strong, you may have some relief during the summertime to prepare for the second wave. If you don't have a seasonal force, you may experience a second wave as soon as you lift your lockdown. So next slide, please. So you can just see what are the options for the lifting of the lockdown. Matthias, you tell me a couple of minutes before the 30 minutes is over, because I don't want to be too long. Yeah?
No, it's fine.
It's fine. Okay. So because I have not seen my okay. So you can see that options are not so many. We have, if we lift the lockdown, and the lockdown is in the middle of my slide, the population social distancing, I name it like that. That was exactly what to do. That was to reduce the contact number. You remember that. So if you lift it, you will increase the contact number. So what you need to do is to decrease the probability of transmission in parallel. So maybe you should impose protective masks. You should impose more hand washing. This may be very, very helpful. If you succeed, for instance, to come from 5 people to 2 people, of course, the problem is by lifting the lockdown options, you will increase the 2 people. Maybe it will increase to 5. So you need to reduce the probability of transmission as much as possible. And there is another option, which is the so-called personalized social distancing measures, what was done in Singapore, as I told you, or Taiwan, and that could be implemented because it has no consequence on the economy or on the social life. You can keep your school open, you can keep restaurants and bars open, you can keep the business, the non-essential business open, but you have to implement a strategy which allows you to mass testing, extensive contact tracing, and isolations and quarantines. You need to be very well organized and invest a bit in these tools and some AI tools to do that. I'm not expecting for the moment any antivirals or vaccines to help us. Of course, as soon as we have them, it will help a lot to control the pandemic. Next slide, please. So testing is testing everywhere. It's testing, mass testing, even in the drive-through and so on. I'm talking about the testing of with PCR, the identification of the virus. Next one, the contact tracing is something where you need some input from engineers and developers and apps and everything. Of course, it may be very intrusive because it may violate confidentiality, but it is completely possible to implement that in democratic states for many reasons. You may not oblige people to be traced. You may just say, just call to their responsibility and their participatory involvement, because when you know that you are positive carrying the virus, if some people ask you, some epidemiologists, I don't know, ask you, is it possible to have your informatic trace, for instance, on your smartphone? Because we would like to know who was close to you in the last couple of days. It is something which is possible to implement, and most probably many people will accept to protect their relatives and their neighbors and their friends if they were exposed to them, and maybe to be tested and to be locked down for them, for sure, to be quarantined at least for a couple of days, maybe 5 or 10 days, not more. Next slide, please. So you may differentiate between isolation. Isolation is usually kept for the people who are sick, and the quarantine are kept for people who are exposed and maybe not sick, maybe asymptomatic, but they don't need to go to hospital for that, but they need to be separated from the healthy people to avoid any contacts. Next slide. You may use this pan-European privacy-preserving proximity tracing, which is an initiative which is hosted in Switzerland and which guarantee a democratic approach of tracing and not something which is too intrusive and not accepted in our societies and according to our values. So next slide, please. Is my conclusions and my last slide. I would like to say that there is a high risk for upcoming pandemic waves, as I told you, and we just can hope that the summertime will provide us some relief, but it is even not sure. We are not in China. It is an authoritarian regime. They have initiated invented the lockdown to secure the efficacy of these non-pharmaceutical interventions which were used in the Spanish flu in 1918 in America. The Europe are deeply embedded within democracy and human rights values. We will not lock down, and we did not lock down at the same violence as the Chinese did, and probably it was as effective. The challenge for us will be to combine these values and an effective fight against the pandemic. Of course, we shouldn't be naive and we should be effective. We may use the other models which are not maybe the Chinese one. We may have a better look on Taiwan, on Hong Kong, on Sweden, on Germany, on maybe the South Korea, all those who used more high-tech and artificial intelligence component to help this social distancing to be more personalized and maybe to be as effective. And probably we should not have too many dogma here. We should sometimes have some level of lockdown and these population social distancing measures. We should probably wear masks and have enough masks to wear, or allow for creating some artisanal masks, handicraft masks. And we should also now combine that with the measure of personalized social distancing. I thank you very much for your attention. I hope I was not too long.
Now, you have showed France as some sort of a hotspot, but if you check regionally France is divided some sort of into East and West. In the East, there is more, there was more happening, and in the West, not, except for Brittany. Did you hear that?
Yes, sure. Yes, in fact, there were, you're completely right. There are some heterogeneity, spatial heterogeneity with this virus, and it attacked first close to the northeast of France, and also Paris was highly attacked. But exactly like in Italy. In Italy, that was the north of Italy, which was attacked. Roma was not so much. And so, but that's the early beginning of the pandemic. It will happen most probably that the other part of the country will be also attacked by the virus in subsequent waves. So we have to prepare to pandemic waves, which may be stronger and longer than the one we have had, which may have been only an herald wave. Even in China, I don't know if you have seen the seroprevalence level in China, in Wuhan, are around 5%, which is not so far from, it's a bigger than what has been reported, but it's not so far from the figures which were provided by the Hong Kong University by modeling. So in a way, we are just at the beginning of the process. I don't know if that was your question, but...
I'm always skeptical about statistics in such an early stage, but anyway, thank you very much.
Yeah, we have to rely on what we have in terms of statistics.
We have Veronica.
Yes, I was wondering, what do you think about the gradual lifting of these restrictive measures? Do you believe these can be truly effective for the healthcare system or just for a little time?
So, if we have decided to lift these measures, first of all, we have to say and to remind that it has been invented by the Chinese in Wuhan in an emergency context. And it has been applied by Italy in the same emergency context. And it has been applied after by France, Spain, and half of the world, with no idea on how to proceed to lift the measures. So when you say, should we lift them gradually or sequentially or all the same day, there is absolutely no guidelines, no recommendations, and WHO did not provide any of them to lift the measures. And there is no experience to do that. So in a way, what I understand from the policymakers is they are taking advices from experts, as I am. I am an expert. I give some advice to my government in Switzerland, but we don't have experience on that. We don't have any textbooks saying what to do to lift the measures. So in a way, we propose our policymakers to take measures which seems to be reasonable, not too quick, not too early, and to try to have these measures lifted in something which is smooth enough to be absorbed by the healthcare systems. What we will want to protect is a new surge in the healthcare system.
Okay, thank you.
You're very welcome.
So we have a question here from Jeffrey Smith. What are your thoughts about group sample testing feasibility?
What do you mean by group sample testing feasibility? If it is about the antibody testing, I think because we have not talked a lot about antibody testing, which is serosurveys. You know, conducting serosurveys should be done in samples, not in the whole population. It's exactly like the political polls. You know, when you do polls before elections, we can do samples, 500, 1,000 of the population, and trying to explore the level of immunity in this sample. And you extrapolate easily to the populations you are interested in. We have done that in the canton of Geneva. We have done that, we have seen that in various settings, and I was talking about Wuhan, who has done that recently. So this is for group. And you may have some specific groups that could be the healthcare people, healthcare workers. That can be any other regions. It can be a hotspot, for instance. And you may see if you reached a herd immunity anywhere. And until you don't have reached the herd immunity, you know that any lifting of the measures will be risky. If you were talking about PCR testing, which is the test to identify the virus, a living virus in a person, in a patient, therefore you can do that in various groups. Usually the best target is the symptomatic people, because you see that the symptoms are very wide, the case mix is wide, so you can ask, even in case of light symptoms, mild symptoms, to be tested. And if you do that, you will have, of course, many other causes of coughing or of fever, which will not be COVID, but at least you will have, you will increase a bit the prevalence in these subgroups.
So, Victoria, can you hear me?
Yes, I can hear you. Can you hear me?
Yes.
Yes, we can.
Yeah, thank you. So I'm from Austria, and I was wondering these days, because Austria is not that big country, I mean, not very high number of population. Is it theoretically and practically, of course, possible somehow to not to split, but to make regions of the country which are anyway connected because of businesses and so on. So we keep restrictions in all the rest of the country and start with one region and let here the first wave or the whole wave, so to say. If this region is very small or small enough that we are sure that all the patients who will need intensive medical care, that we have enough places for them in the whole Austria, so we can transport them to the rest of the hospital in the country. Then we have herd immunity in one part of the country. And then these people can continue theoretically living normally. So we go on to the next part of the country to split one country in small pieces and let the normal wave completely, like Sweden is doing at the moment. Is this kind of solution possible? Or
yeah, sure.
Does it make sense?
Yeah, thank you for this question. I think it's very pragmatic. In a way, you know, the definition of what is a country or what is a region is something which is very flexible or variable according to the country you are talking about. If you name a region in China, it's more than a big country in Europe.
Yeah.
So in a way, what we have to do is to think locally in terms of, I think the main criteria is the risk of surge, of bottleneck in the healthcare system. What we need is to be able to secure high quality care to everybody, not only for the coronavirus, but also for other disease. You need that a myocardial infarction is taken in charge within 90 minutes after occurring, because we know that after 90 minutes, you increase the risk of death after myocardial infarction. Just to take one example, if you don't have the healthcare systems available to do that quietly with the high quality we have known for decades and which has led to this dramatic improvement in life expectancy in our countries, we will lose some benefits of this progress in medicine and science. So what we need is to protect the healthcare system and to allow the healthcare systems to treat adequately all the patients with the coronavirus and with other conditions. And for that, it may be done at a very local level. In Switzerland, where we are a federal state, we can do that at a canton level, and some cantons are not very populated. In France, they hesitated to consider working by regions or nationally, and finally they decided to work nationally. But you know, this country is a centralized country. So it may happen that because of your culture, I mean your political culture and your administrative culture, you have a more local driven approach or a more centralized driven approach.
Yeah, thank you.
You're welcome.
Okay, so we have a question here. Is there a consensus on how contagious are the asymptomatic? Should we track and isolate them to prevent a second wave?
Oh yes, it's a good question because we don't know so well. It's not easy because of several reasons. First one is asymptomatics usually are difficult to track and to detect, except if you perform a systematic survey. And it's not easy to know at what stage you have been infected and if that was when you were in a contact with someone who was asymptomatic or symptomatic. What is true for many viral disease, and particularly respiratory viral disease, is that you are more contagious when you exhibit symptoms like coughing or sneezing, than when you don't, first. Second is when you exhibit symptoms like fever and also coughing and so on, you usually refrain yourself to multiply your contact numbers. So you have less contacts, but you are more contagious. And when you are asymptomatic, and I would say pre-symptomatic, you don't have any symptoms, but you are probably less contagious, but you have much more contacts. So you multiply your contacts because you are not aware that you are carrying the virus. You have no symptom at all. But when you speak, you have some droplets, the phleg droplets, and these droplets may be contaminated by your infections, which is starting. So it is quite possible theoretically that the level of transmission is compensated by the high level of contacts before your symptoms occur, even if the level of the probability of transmission is lower. When you are completely asymptomatic and when you remain asymptomatic, you carry the virus because you have been tested positive. What does that mean that you have been tested positive? That means that in your throat, you had some living viruses. And when you speak, just speaking without any symptoms, you push some droplets and you may contaminate people. So theoretically, there is no reason that you don't contaminate people. Of course, with symptoms like coughing, you contaminate more. And this is a very strong reason to encourage people to wear masks, protective masks.
Now we have another question. Do innate immunity responders have the same long-term humoral protection as more severely infected patients?
Again, I will apologize to tell you that we are not completely sure of everything with this disease, which is a new disease. But we have some reference with previous diseases. And what is sure is the more the viral load is, the more the protections and the level of antibodies is. And it has been shown also for this virus. So for the coronavirus, those who have been hospitalized in intensive care with severe pneumonia have a stronger immunity response and probably higher antibody levels and probably for a longer time. Of course, this long term is not yet well known, and it needs to be confirmed with time. What is also probable, and the consequence of that, is as asymptomatic people may have very low and limited level of antibodies in their blood, but maybe they will be protected, enough protected to avoid acquiring new infections with this coronavirus. It's not completely sure, but to tell you, I have not seen one convincing case of reinfection with this coronavirus. It has been told that there were some in South Korea in particular, but it was not very convincing because, as I told you, the tests are not sensitive, are not completely specific sometimes, and you may face a test which is negative, but you were infected, and after it's negative again, and you are still carrying the infections, and you seem to be reinfected, but it is not exactly the case. Over from me.
Okay, so we have one more questions, and then we try to upload the video again. It's, hi there, you mentioned the pandemic can be considered under control when immunity is above 70%. How do you measure immunity?
So there is maybe two questions in your question. One is how we calculate this 70%, and this is a formula from the theoretical epidemiology, which is not very difficult. I did not put it on my slides, but it is 1 minus 1 divided by R naught. So if R naught is 2, I said it was between 2 and 3. If it is 2, it is 1 minus 1 divided by 2. This is 50%. If it is 3, if the R naught is 3, the level is 1 divided by 1 divided by 3, which is 66%. So we think it is closer to 3 now. And the reason why, and maybe a bit above 3, the reason why I'm saying that 70% is a safety guard. But of course, it may be between 50 and 70%. So this is the immunity which is needed to, not to avoid any infection, but to avoid any outbreak, to avoid that the R will again goes beyond, above 1. So this is the theoretical epidemiology concept. So the second part of the question is, how do you measure immunity? Just by the level of antibodies in the blood, in the serum. So you can, if you have developed a disease, if you have been infected, you will develop antibodies in your serum, and these antibodies are measurable by an ELISA test, which is a serology, and this serology will tell you if you are immune or not against the coronavirus. If you are seropositive against the coronavirus, it means most probably that you are immune against this virus and you will not be reinfected. Of course, if you have a vaccine that will provide the same kind of immunity, you will be immune against the coronavirus thanks to the vaccine. But until we don't have 70% of the population immune against the coronaviruses, we will face new outbreak of this disease, most probably.
And now a final question. The CDC recently said that believe the herd immunity threshold for SARS-CoV-2 may be 85%. I don't know the details of why.
So this is the reason. What I told you, I give you figures which was between 50 and 66%. And at the end of my talk, I say maybe now it is 70. And there are some new researchers measuring things, and particularly the R0 of several outbreaks, and say in fact the more steep is the slope of the epidemic curve, and the higher is the R0. Sometimes the R0 is 20. For the measles, the R0 is 20. For influenza, the R0 is closer to 1.5. Here, it seems to be closer and closer to 3 and maybe above 3. If it is above 3, it will be above 75%, and it can be 80%. So if the R0 is very, very high, you will have a high proportion which needs to be immunized before stopping the epidemic trends. But when we will reach 70%, we will not be at high risk of big outbreaks anyway.
There is a thank you from all participants to you. And I will now have the opportunity, and I would like to introduce you to Evelyne Bischof. She is a medical doctor and associate professor at Shanghai University of Medicine and Health Science, and attending physician at the University Hospital in Basel. She has been in China during the whole crisis from February, and it was there during the lockdown, and she will now, and I will try to.
I apologize that I cannot join the webinar in person, but I would like to send my warmest greeting from Shanghai, from China, where I have been from the beginning of the pandemic, at that time still the epidemics. I am very, very pleased to join, at least per video, and share some experiences and some observations on how China has implemented measures to prevent and to mount against a potential second wave of the pandemics. And I believe it will be very valuable for other countries to see this example and see how it can be modulated, modified, or potentially translated partially in their systems. For this purpose, allow me please to share my screen so that I can give a quick overview of these measures, really just a few minutes. So the question is really for everybody at this moment, what happens after the curve has flattened? And just for my quick introduction, in case Matthias hasn't done it at the beginning, I'm a medical internist. I'm an internist, medical doctor, and a master of public health, and I'm an associate professor here in Shanghai at the Shanghai University of Medicine and Health Sciences, and PhD candidate and in Napoli, Italy, and also affiliated with the University Hospital of Basel in Switzerland. Also, I'm executive committee member of Women's Brain Project, which is our group where we strongly advocate for precision medicine, specifically also now in the COVID era. And actually, I am here in China partially because of Women's Brain Project. Now, coming back to the topic, so the strategies to avoid protracted restrictions were facilitated, and although some leniencies have been now implemented and some restrictions have been banned, still the relaxing of the lockdown was very much announced with a full alert that should remain for a potential second wave. And so we could observe and live as people here different measures that were implemented. So first of all, there is an extensive testing and contact tracing going on. This is very much transparent. We all have our QR codes with different colors depending on where we have been, which areas of potential risk we have attended, that. So this QR code is changing automatically and has to be updated often, and is really helpful in order to identify potential asymptomatic infected persons, and also to trace those who have been in what potentially retrospectively turns out to be a region of risk. So there is a continued vigilance also seen in the public, although there is in most of the spaces no more obligation to wear masks. Still, it is very rare to find someone without a mask among specifically the Chinese population, being very much aware that wearing mask was something not unusual even prior to the COVID-19 pandemic. Now, the quick identification of infected individuals and rapid isolation is something that is still very much practiced. So the extensive testing is definitely very helpful in that identification. There are still some temperature measurements going on in places such as hospitals, smaller clinics, and so on. And rapid isolation is, in fact, done very, very effectively. Now, I'm speaking from a perspective of right now. I will be speaking of the isolation of the returnees and all the travel area a little bit later, because this is a whole different topic and more complex. But here I'm talking about really from the general society. Those who are being identified as potentially infected are being tested and then isolated. So the society has also been receiving very, very good, very well tailored and very understandable, comprehensible public health messagings. They were very, very much done for the people, and at the level of their health literacy, they were very much understandable and so translatable in the daily life. So we can still see that people are keeping social distancing practices, perhaps not in terms of being really very much isolated, but in terms of not being in big gatherings, also wearing masks in the public and sneezing into the elbow, and so on, shake hands, washing hands, different practices to prevent the resurgence are definitely still in place very, very much. What is probably very positive, on the other hand, a little bit frightening, is the school reopening that is planned, but this is being done very progressively, with a little amount of schools being open first and with a very close monitoring. So it will be most probably a kind of an experiment, but again, the measures are not being done at one time and promptly, but really in a process with a very, very high level of vigilance. Now, there are also aids of reporting of and specific measures for asymptomatic patients. So due to extensive testing, we can see that we have a lot of asymptomatic patients, and they are being immediately and very, very quickly reported. For example, if there is a patient in a hospital and is being tested for COVID as a part of precaution, for example, prior to a surgery that was elective, and is being tested positive, immediately there is a quarantine in a specific place for 14 days. Not necessarily at home. This is again dependent individually. And there are also still very, very vigorous disinfecting efforts in the public spaces, on the roads. They are very, very much prevalent and very active. However, all those precautions started even before the curve was flattening. So when there was already this trend, we could see that China, for a very long time, had the airways open for the returnees. So people who live here, the residents, both foreigners and Chinese, were able to come back, especially when the situation in China was improving. It was very important for many people to return as the pandemic was emerging in other countries and unfolding there. So, for example, in China, we had a very, very strict protocol. In Shanghai, I mean, we had a very strict protocol at the airports. This was very similar in other places, although I have to say Shanghai was, I believe, one of the most open airports at that time, as the city was not that much affected by the epidemics due to fantastic public health measures prior. So, for example, when returnees were coming back, they had to undergo board checking. So they were checked on the plane, they were interviewed on the plane, they were checked upon exiting the plane, again in the entry-exit hall, with filling up a lot of declaration. They were, however, all also automatized, so somebody could do it online up front. So the huge amount of additional steps, and they were increasing in time, did not necessarily mean a lot of time spent at the airport in the beginning. Later on, it was of course different when the measures had to be increased to a level where every single person had a multi-step screening at the airport. And later on, if the label of the QR code or the label in general that was given to a specific person was red or yellow, because then actually the whole procedure started. However, as you can see, the public health communication again was very good. Everybody was informed about the procedures. We were constantly updated about which countries are in the high and middle or low level risk. We were constantly updated about what is the procedure for a person in a specific category, and so on. And as you can see, even here in the official message, it was constantly reassured that one should be relaxed and honest and not pace and not stress and so on. However, indeed, the entire procedure, as you can see here on a graph, was definitely time-consuming. So a person, upon arriving to Shanghai, if it was not a green label, it means no symptoms, no history, and coming from a country that is low risk or no risk, was able to go home and be there in their own apartment, perhaps with their own family, no problem. People who are in the yellow label, however, coming from high-risk countries, did have to go to a specific designated place, a hospital that was testing them, and upon receiving the results that were negative, they were transferred to their homes, but they had to be quarantined for 14 days, very strictly. They could not leave their houses at all, and they were being also checked upon or monitored with a specific device to break the quarantine. And those who were in a red label had a quite similar path, but a little bit more restrictive in terms of who they were allowed, for example, to be in the house with, or if they had any symptoms, they were immediately quarantined, of course, in a specific designated hospital and not at home. With this, I would like to almost conclude. Well, all these procedures are now in the past. Since March 28th, the flights for returnees have been banned for foreigners returning to China. And this was a response definitely to the unfolding pandemic in the world. Yes, I believe I do not have to comment on that more. Definitely one of very important measures, because as you can potentially remember, most of the cases that were reported post-flattening of the curve were coming from returnees, and most of them from foreigners. With this, I would like to say thank you very much, and I wish you a beautiful rest of the webinar. And I'm here. You can reach out to me via Matthias for any questions or comments. Thank you very much. Goodbye.
So we are now at the end of this webinar. If you have questions or additional questions, please send them to us via email, and we will get in touch with the panelists and we will get back to you. We will also inform you about the future seminars we are planning. There is one planned on fake news regarding or in relation to COVID-19, and we have other seminars in planning also related or the COVID-19 and the SDGs, etc. But we will send you information via email and invitations too. So thank you very much, everybody, and I hope you did enjoy the talks from Antoine and Eva. Thank you and good night. Have a safe and healthy weekend. Bye-bye.